This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2016, all rights reserved. My name is Shauna Strickland. I am a respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, The Accidental Preceptor. Upon completion of this AARC webcast, participants will be able to describe how adults learn best, discuss challenges in clinical precepting, discuss best practices for educating students or training new employees in a clinical setting, and explain effective strategies for evaluating students or employees. I am pleased to welcome Dr. Crystal Dunlevy. Dr. Dunlevy is a registered respiratory therapist and associate professor in the School of Health and Rehabilitation Sciences at The Ohio State University. She has over 30 years of experience in respiratory therapy and higher education. Dr. Dunlevy is a frequent presenter at AARC Summer Forum and AARC Congress, is a co-chair for the AARC Diversity Committee, and is an author of the AARC Clinical PEP, Practices of Effective Preceptors. Neither Dr. Dunlevy nor I have any disclosures to make. Any brand names of products or medications that may be mentioned are only done so as examples of technology. Dr. Dunlevy, welcome to the program.
Thank you. Hey, everybody out there in TV land. So we're going to talk about precepting and, our preceptors made, our good preceptors made or born. We're going to kind of go over some tips and strategies if you find yourself in the position of having to precept students or mentor new hires, new employees when maybe that's the last thing you want to do. So here we go. And I'm not telling you anything you don't know when I say that respiratory programs rely on the preceptor model. That's how we train respiratory students. And that's typical of most professional programs, right? Whether it's nursing, dentistry, medicine, preceptors are used. Now, the preceptor model may be the educational institution pays a preceptor, or a preceptor is paid by the clinical site, so that you have a little more control over, what happens with the preceptors. But most of us, get assigned a student, or there are a few people that usually take students, but if somebody calls out that day, somebody else might take the student or the new hire to do some orientation. And just like in administration, sometimes if you're good at your job, you get promoted to something you don't want to do. So if I'm a great clinician, maybe I want to be a great clinician, and I don't want to precept students, and I don't want to have a job in administration or management. And that's a lot of the time the way preceptors are chosen, because they're great clinicians. So these characteristics that are in front of you are characteristics of good clinicians. And obviously we don't want a preceptor who's not competent, but if you notice the skills, right, they're competent, and just to move to the last one, technically adept. They're technically really good at what they do. They're really detail-oriented. And physical endurance. I mean, if I'm, doing a 10-hour shift or a 12-hour shift, I have to have, some physical endurance. So these are things that are, hard skills. And so I may or may not have the social skills to go along with it. And that may or may not be important to you. If you have seen the doctor, which is old now, I have to admit, but he says, I'd rather you cut straighter and care less. And so if you're a clinician who doesn't want to be a preceptor, maybe that's what you think. It's important that I'm clinically great and I don't have to be your friend if I'm doing, patient care, or if I have a student, this is what it is. So people generally kind of, fall into those two camps. I need to be good at my job, and the student can just, hang on and go for the ride. Or here are, some ways maybe to make them have a better experience. Because the bottom line is we want to create students who are good clinicians, right? So you have to be competent, but those kind of more social skills, more the affective domain come into play if you're going to precept students or be a mentor to a new hire. So, and as if you don't have enough to do, right? So in your spare time, you have a case load that you have patients that you got to see. You have unplanned work, right? Because the nature of the hospital is fluid, right? So you may have lots of unplanned things come up that you weren't anticipating, and in your spare time, then go ahead and be an excellent preceptor to a student or a group of students, or mentor some new employees, get some orientation done. So I want to ask this question. So this is your polling. Have you ever found yourself in the role of accidental preceptor for students or new employees, where you're like, yeah, I don't know if I want to do this, but here I am. So take a minute to check, do the green check for yes or the red X for no. And while you're doing that, I'll just say, even if you have a group of good students or a good student, even that adds to your workload, right? Because you have to kind of follow them and make sure they're doing things right, and maybe you have to sign off on their charting. So even if you have somebody good, it adds to your workload. And if you have a student who's, I'm going to use air quotes, challenging, then your clinical day can, go down the drain in a hurry. So, and that the challenging piece too, I mean, if there's something really clear and identifiable as a problem, then the fix is a lot easier. So if you have a student that's late or, doesn't have the right color scrubs on or something, that's easy to solve the problem, right? You can send a student home, whatever. But the problems that happen in the affective domain aren't so easy to fix. So it looks like I have slowed down. You have slowed down on the polling. So Reagan, if you will let us see the responses, that would be cool. So most of you did not reply. Sad and sadder. No. So it looks like most people, right, have so 63 people have found themselves in the role of accidental preceptor, and very few of you that responded have not. So anyway, lots of us get, precepting foisted upon us. So let's talk about, if you are an accidental preceptor, here are some tips to, maybe improve the way you're doing things. If you're a seasoned preceptor, maybe you'll get a takeaway, who knows. So we're going to talk about adult learning first. And even if you have some respiratory students that are young adults, they're still adults, right? Although by their actions, who would give them adult status sometimes, I know, but they're still adults. So one of your responsibilities as a preceptor is to treat them like adults, because you are, giving them control over, patients' well-being. So we have to treat them like adults. So adults tend to be sort of self-directed, and they like to be autonomous, right? They like to be, independent. And so I think, obviously they have to demonstrate competence before you allow them to do that, but it's important to let them, take on some responsibility when they're ready for it, and take on a leadership role if that's appropriate. And they are also, they also do better when they're given a little freedom and allowed to work with, less supervision at a certain point. You can let them work on projects that reflect their interests, and sometimes that's possible and sometimes it's not, right? So sometimes you can say, okay, let's, what about this project? But that isn't always the case. So I'm not saying you have to, bend over backwards coming up with, adding to your already stressful workday by making a project that will, reflect the student's interest. If you can, it's a good idea, and adults appreciate that, I think. And the point, I'll say this over and over again, but the point is to turn out somebody into the world, just like you would your kids. Like with my kids, my goal in life is to turn out people into the world that are good, right, and caring and empathetic and nice people. And with a clinician, you want to turn out somebody who's competent, right, is kind of your goal. So the other thing adults like to do, and if you have, some older students, this is even more important, is to use their life experience and what they already know. So if you have some student who was a member of the wait staff, right, they're probably, have decent social skills, because that means better tips. So they can use their social skills at clinical. If you have somebody who has experience in retail, then they're probably patient. So they like, to use things that they have experienced and things that they know. Sometimes it's obvious. So like if you have a student whose parent or maybe their grandparent used oxygen at home, they'll have kind of an affinity for trying to know more about that, or because they have a natural, practical connection to it. So that's important to adults. The other thing is, and I think this is important just in general, to let the student know what they're going to be doing during the clinical day as far as you can. So let them know what the goals and objectives are for the day, even if it's in general terms. Let them know what's going on. And it also, if you do that, fosters accountability in the student, right? And which I guess goes both ways, because it also makes you as the preceptor accountable to let them know what the plan is, right? So I guess that can cut both ways. Adults like to learn things that are practical and relevant, right? So they don't like to, remember when you were in high school and you had to memorize the periodic table or something, or in chemistry? When did you ever use that again? You really don't ever use that again. It's not like practical things, Even math, the math, people are not going to like this, but really, once you get into the wide world, you pretty much have to know how to add and subtract and multiply and divide. You don't have to, calculate sines and cosines. So, and there's some math they have to know to pass their boards, but really, keep it relevant, right? And that's important. The other thing I'm going to say here is it's perfectly acceptable for them not to have to work every second toward that particular clinical rotations goal. So, whether that be ventilator management, pulmonary rehab. So they don't have to spend every second on that, but the majority of their time should be spent on a relevant task. So if they're there to do a certain rotation, they should be mostly doing that, right? And when people in general and adults understand the practical reasons behind the therapy and treatment, they're better able to learn it, and they tolerate it better. So if you have to do some really boring or mundane something, just say, okay, we have to do this, and I know it's boring, but we have to do it because these reasons, whether it's inventory or oxygen rounds or whatever, because that's why it's called work and not recess. You're doing some things that you can't be entertained all the time, which I think, I don't want to go on a rant against the millennials, but sometimes people kind of expect that they're going to go and see fabulous and unusual things in the ICU and the ED every second, and then they get annoyed if they don't. So this is just the games model for adult learners. So, and this really probably doesn't require much in the way of explanation, but setting goals important. Active learning, hands-on learning is what people rate as the most meaningful activity that they do at clinical, right? And that's the thing you provide that they can't get in school, because it doesn't matter how many times you practice it on your friend in the lab. You really kind of doesn't come together until you're doing it on a patient. So that's way more effective than passive lecturing, and that's sort of your goal in life as a clinical preceptor. And they also learn better if something is meaningful to them. So you might have to provide, that's really the next one, give thorough explanations, but to make it meaningful, you might have to do some explanations, and that is sometimes time consuming. And maybe you can't provide a thorough explanation for everything you do, but as much as is possible, it will pay off for you in the long run, because that makes for a better student and patient interaction, right? If they understand what they're doing, they feel like it's important. And explaining, how to do things, why you're doing things, that makes less work for you later when you're trying to correct a mistake that they've made, I think, too. And obviously, self-regulation just encourages somebody to be responsible. Take responsibility for your own learning. If you're at a rotation that you feel like it's boring and you fall asleep or something, that's on you as the student, right? That's on the student. You have to be responsible for what you're learning, right? And that's easier said than done, but it's your job to teach them that. If I make someone cry in the office, then I'll say, well, you've learned a valuable lesson in self-regulation today. And then they thank me. No, they don't thank me. So other tips, and this is all, the soft skills, kind of social skills thing that people who have social skills really, if you're listening to this, you do this without making a list of what you're doing. So make the students feel important and invited. And we all know the clinical preceptor, we may have even had one that makes you feel every second of the day that like, oh, I got a student today, or I got to take a student today. And you don't feel very invited. So even if you don't want them, you should pretend that you don't mind that they're tagging along. Nonverbal cues. I'm going to say 92% of communication is nonverbal. So actually pay attention if they're talking to you. Make eye contact with people. And there again, I'm sure you make eye contact with people, but if you don't have these skills, then you got to make a conscious effort to do that, right? To make eye contact, because people think it's weird if you don't. And get to know something about the student personally. Right, and that's just a social skill, and that if you know something about them, that develops a better relationship, and they are more likely to trust you and listen to what you say and transfer that hopefully into a patient interaction. If you interact with the students in that way, hopefully they'll transfer that to how they interact with patients. Empathize, with the student, because students are, sometimes they're afraid. They're afraid that they don't know something. And I can remember, and when I used to do clinical instruction, I would say this, I remember sitting in a room in the 1920s, but I remember sitting there like dreading the next oxygen call, because I would be like, oh, I hope it's not a cannula, right? And we all think that's silly, but the student, sometimes gets scared over things like that. So you kind of have to remember that and be a little empathetic. And be enthusiastic. Not that you have to be like, patronizing or over the top, like cheese-tastic about it, but at least pretend that you like what you're doing. Like in class, I don't have to, I like what I'm doing, so I'm enthusiastic, and people get that from me. And if you're not enthusiastic, maybe, at least try to be neutral instead of like, oh, I can't believe I got into this profession. What was I thinking? Motivating people. So I'm going to go back to this slide just for 1 second and say that these skills are also things that somebody who's like like a really good clinician but doesn't care about the social skill aspect of it, that they would look at the slide and be like, that's ridiculous, and why do I have to do that? It's not important. So if you were thinking that, no, I'm kidding. So motivating students. So everybody's motivated by something, right? And one of the ways to motivate your students is to do that by example. So if you are excited about what you're doing and let's learn something else, because the other way that you learn as a preceptor or somebody who is mentoring a new hire or doing orientation, sometimes they will ask you a question maybe you never thought about it before. It's one of those things like, oh, we've done it that way for 20 years. I didn't even think about that. But I learn from the students too. So it's not just a one-way street. And if you're stressed out because you have a student and can't wait till it's time for lunch or break or to leave, then your students will pick up on that and, be that way too. The other thing, if you're giving them a task, you have to think carefully about, where they are. Because if you give them something that is too hard for them to do, then they get really frustrated. And if it's too easy for them to do, then they're bored. And so you kind of have to try to, and that might take a little minute, and you don't always have to hit that perfectly, but, try to do that as far as you can, because it just, makes your life easier too, because then you don't have to deal with them when they're frustrated or bored. I had a clinical, here's how old I am. I had a clinical preceptor back in the day who was always like, well, when I was in school, we had to take apart an IPPV machine, with tweezers and a piece of string and put it back together, and you all don't know anything. And so sometimes he would put us in a room and be like, see if you can take it apart. And I was like, are you kidding me right now? When would I ever have to like do this and reassemble an IPPV machine in a patient's room? But there you go. So be careful about that, because you don't want them telling a story on a webinar that they are doing 30 years later. It's very sad. So retaining information. So you have to hear things 3 times before you remember it. So says the evidence. So you want to give them lots of practice and lots of application. Like practice doing this, but here's how you apply something you learned in class or lab to the clinical setting, right? And that's just doing and doing and doing. And that's, that's nothing that you didn't know before, but right, you've got to make it stick by having them do a lot. Transference also important is how do you use, and that's back to the practical application that we talked about a second ago. Use what you learned in class and lab in the clinical setting. So if you sat in class and learned how to interpret a blood gas, and then maybe you ran it through the machine, the fake blood through the machine to get a result in lab, so you learned how to use the blood gas machine or whatever. What does that mean in the clinical setting, right? And you can go over that in class all you want, but until you see a patient that, okay, these blood gases mean we need to make these ventilator changes, or the patient is likely to have XYZ physiologic profile because of this blood gas. That's what is important, right? So the preceptors do the important piece. And even if it's a new hire, they've just learned that stuff recently, right? So it's also good to, kind of reinforce those types of things with a new hire too. So let's talk about the people that are challenging. The challenging people. We could do a whole hour on each one of the challenging people. But anyway, you're doing just like you would do in a clinical setting with a patient. You're doing two things. You're diagnosing the problem, and then you're making an intervention or a treatment plan, right? So you have to figure out the reasons behind the student's behavior first. So why are they doing this? Is this a typical thing they do, or is this out of character for them? And we'll talk about examples of how to use these things in a few minutes here. But first you got to figure out what the problem is, and then you have to intervene, right? So an intervention is the most important piece, but it's a piece that people don't like to do when they're precepting or mentoring a new employee, because you don't want to get the person in trouble. We had a student a couple of years ago that was a horrible, horrible clinician, but he had like really good social skills, so people liked him and didn't want to give him a U because they didn't want to get him in trouble, or so yeah, sometimes you have to like intervene even if it's uncomfortable. So, and when you intervene, you have to have detailed explanations that are very clear. You have you should do feedback often, right? That's honest and direct and timely. Communicate with the respiratory therapy program faculty. If you have somebody at your site, and we'll talk about examples again, but that is just like doing a horrible job, maybe they need to go back and get remediated, right? So I think it's also appropriate to call the faculty if you have some problem and you think, I don't know what to do about this, and then commit. You got to follow it till the end, whether it's ugly or not. So let's talk about some specific examples. This slow student, or this employee that you're like, listen here, we got 8 hours to do orientation, and I can't stay here with you for 16 to get it done. So here's what might be the problem if they're slow. They might not understand how long it takes to do something. So, and this is probably more typical of a new student who's not, that confident in their ability. So you might have to just, like I'm, a huge proponent of just being direct. So just say, listen, you got 20 minutes to get, XYZ treatment done, and we have to pay attention to the time or else we can't do everything on the list, right? As is true in life. I mean, so if they're unfamiliar with time expectations, that might be an easy fix. They might have some cognitive or psychomotor or something going on, and that probably needs to be addressed at the educational program level. But if there's no physical reason or cognitive reason, they may need, remediation as well. So you may have to just send them back to the drawing board. Because the other thing is, if you don't have time, you got to send them back to somebody who does have the time or will make time to assure that a certain level of competence. They may be afraid that they'll, mess something up. So they are really slow at it because they're being too, I shouldn't say too careful, but too careful and spending too long in every piece of it. And that can be fixed by just having them practice it. Okay, if you're changing a ventilator circuit and you're afraid that, you can't do it fast enough, then go practice it in a room 14 times and then come back. So it's really important not to ridicule students or intimidate students when they make mistakes, because then that makes fear of failure even, that makes them more anxious about failing and being afraid to fail. Instead of saying, listen here, I remember when I was afraid to set up a nasal cannula. It's not, everybody is nervous about doing things the first time they do it. So, kind of empathize with that. And the other, this is the one we dislike the most. I won't say hate because we don't hate, but if we did, we would hate this. They take a long time so they won't have to do something else. So that can be easily fixed too. So you have to just say, listen, you're going to have to do 3 things, and if you're here till 10 o'clock to get it done, I'll sign you off to somebody else. That's mean. We would never do that. The poor communicator. We see these people every day, so we don't want to see it in the students. So these are a list of, this is a list of, poor things poor communicators do. They're either, just blunt, and we'll say, I had a student once who was like, oh, you look way worse than when I saw you yesterday. And everyone's like, wait, you just used your outside voice. So sometimes they're just blunt, and that is an obvious problem. Sometimes they don't show any empathy. And remember, nonverbal, 92% of communication is nonverbal. So the nonverbal things like, maybe eye rolling, or maybe they have, resting bitch face, which is what I suffer from. And people are always like, oh, what happened? Or are you okay? Yes, this is just, what my face looks like, sorry. But I have to make that a conscious effort to, if I was in a patient interaction, to, be at least neutral. So that, you have to fix those types of things. Condescending and overly familiar also are problems. The other thing is if you seem like you're in a hurry, right? You're only talking about the treatment, and when you tell students, you need to talk to them about something besides the treatment. They'll say something like, "Oh, how's your day going?" Well, the person's in the hospital, so their day could be better. So say something about, "Oh, who sent you those flowers?" or "Who sent you that card? Who drew you that picture?" You talk about what's on TV in their room. Talk about local sports. Try to talk about something else is a good thing to tell a student. So all those things are important to keep in mind. So how do you deal with somebody who's a poor communicator? So do you see Dexter at the bottom? If you are fans of Dexter, even if you're watching it on Netflix and you didn't watch it when it was on Showtime, you know that Dexter, is a psychopath, so he doesn't know how to act. But he understood how to act by watching other people. He learned what was appropriate. And so even if you have somebody who's a poor communicator and you feel like, and lots of people have repeated this sentence to me, I can't teach someone empathy, I can't teach someone a social skill. Well, that's probably true, but you can teach them some, cues or kind of go-to lines that they can use. So the first thing that you have to do if you have a poor communicator is just make them aware of how they're coming across, and with examples. So you might say, you were a little bit, short when you did Mr. Jones's treatment today, or Nurse Ratchet said you were, seemed rude when you asked her for the blood gas results. So you kind of have to make them aware of how they come across. And again, I make a conscious effort to look not so mean, I guess, if I'm, in class or in an interaction with a patient or something, because that's just how my face goes. So the first thing is making them aware, and then, talk to them about what you think of that behavior. So sometimes if it's really bad, then you can say that, but say, you might not notice this, but here's how other people think about it. And so I think you should do, this. I think you should make a conscious effort to, smile when you go in the room and introduce yourself, or whatever it is. But how do you see it as a seasoned clinician? Then you have to set standards for what's acceptable. So if you did this wrong, here's how you should correct it. And again, here's an activity that, like, if you're talking about teaching somebody empathy, I used to have the students do this thing called fear in a hat. And so you have to, they can do this with each other to practice is the point I'm getting to here. But maybe the staff, if it's orientation, or other students, write something you're afraid of. on a piece of paper and put it in the hat. And you're not allowed to say, like, I'm afraid of heights or I'm afraid of spiders. It has to be something like you fear. Like, I'm afraid I won't be able to get a job, or I'm afraid I can't get into grad school, or something you have a real concern about. Put it in the hat. Then the student has to draw a piece of paper out of the hat, or you could use a bedpan if you're at clinical. I like that idea. And they have to, in a couple of sentences, show empathy, right? And all it is because sometimes they'll draw something and they're like, I don't know. But all it is, letting them know that you hear what they're saying, right? So if you have Mr. Jones and he's like, I don't want to cough because I'm afraid of that it will hurt. So then, you might say, okay, well, I get it. Nobody wants to be in pain if we don't have to, right? But it's important for you to cough so you don't get a lung infection. So what about if I show you a technique called splinting that will help? And, so just teaching them kind of lines to, right, or I hear you. Nobody, wants to kind of repeating, or rephrasing what the person's saying to let them know that you hear what they're saying. And that practice is important. And then it's important to set up a time, like maybe, they're practicing and they say, okay, I'm going to watch you interact with patients for a week or so. Then we'll sit down again, talk about how you're doing, what improvements you made, and we'll talk about how to do that when we get to evaluation. What about somebody that's unmotivated? You all have these people that the student does not want to be there. And if they've done 100 MDIs, but there are MDIs on the assignment they have today, it's hard for them to stay motivated maybe, but sometimes that happens. And I don't mean to imply ever that if you're orienting a new employee or if you have a student, you have to, make it fun for them all day or relevant for them all day. But, insofar as you can. So back to the MDI example. If maybe you have a second-year student who's like, I've done 1,000 MDIs and seriously I'm doing more. Maybe they could help a first-year student that is struggling, or is somebody that's inexperienced with MDIs. And so maybe you can find something to do, maybe you can't. But if you can, give it the old college try. Set clear up expectations. So the other thing that annoys us all is if, the student that had, okay, I have to do 10 intubations, and then there's an 11th one, they're like, well, I needed 10 and I did 10. Oh, seriously? So you don't need to do another 2. So that, I don't think there should be any, whining about that. But, tell them up front what you expect. And I think that's perfectly reasonable to say, here, I expect you to do this without complaint, even if it's something that you didn't do before. If they complain, then you can do it. But, are they bored chronically? Are they bored every day? Or are they only bored today? Right? So if they're always unmotivated, then maybe they need to pick something different to do. If you could care less about what you're doing every day, maybe you are in the wrong profession. And I would probably call the respiratory program faculty, saying this kid is like bored out of his mind or her mind every day. But if the problem seems unusual for that particular student, maybe something else is going on that just a conversation will get to the bottom of. So maybe something's going on in their personal life that's distracting them and they're not really motivated. They just have their mind on something else, because you all know we can't, leave that, what goes on in your personal life at the door. And maybe, it's something that they aren't interested in, so that maybe they like ICU better than rehab. So even if you say something like, I know you really like the intensity of the ICU, but since you have to do a rehab rotation, let's figure out how we can make it less boring for you, and then make them give you some suggestions, or, hold them accountable for, taking accountability for their learning to make it more relevant to them. This student gets on our last nerve and jumps up and down in it too. When you are doing something and they're like, but it said in the book, don't ever start a sentence with, it says in the book. So instead of, because what we all want to do when someone says that is, oh yeah, well in the real world, here's what, and then finish the sentence. So it's important to kind of, affirm what they're saying. So, like, if you can't put a COPD patient in Trendelenburg to do CPT, you could say, you're right, that's true, Trendelenburg is the best way to drain the lower lobes, but Mr. Jones sat circles the drain when the head of his bed goes down. So in this situation, we're going to keep him flat. So if you kind of stay calm, even if you don't want to be calm, even if you think they're kind of a jerk, it keeps the situation from escalating. And again, you're modeling how to act for them too, right? And so you need to sort of lay out for them how to marry what they know from the book to clinical experience, because it's not, it's not always the same. We all know that. So if you have a challenging student, bottom line, you should take the problem seriously. Use the resources that you have, right? So if you need to send them to a room to practice, if you need to send them back to the educational institution, use the resources that you have. Communicate with the person, right, to try to fix it first. If that doesn't work, then you might want to talk to some colleagues about, have you been with this student before? Have you seen this problem? Have you had a student with this problem before? Or do you have any advice for me? Call the faculty. So communicate with people and then make a plan and reevaluate. And if there's no progress, then you have to give the person a U sometimes, or an F or whatever. At OSU, we don't give people Fs. We give them E's. Did you know this? Which is crazy to me. An E is like an F, so I don't understand it. But anyway, sometimes you got to fail somebody, right? Because sometimes they don't have any business leading the clinical rotation, and that's how it's going to end. So too much observation. There are clinicians who are like, they're not going to do it as well as I can, or I don't want them to make a mistake, or whatever reason, so they're just going to watch for the 100th time. So, and I'll give you that most experiences begin with observation, right? You've got to move beyond watching, though, because if you don't, then they'll get frustrated with the whole learning experience, and they can't do some of your work for you then. It's crazy. So let them do. Once they're competent, once they've demonstrated competence and they've done the check off and you feel like, okay, because they're not going to do it as well as you would. They're not. And they might make a mistake, but, you got to let them do it. And I've said this before, but the trait most often listed as desirable by every professional program, nursing, medical students, dental students, just about every allied health profession that's been studied, the trait most desirable is hands-on experience. So the more hands-on experience they get, the better they like it. And it really takes a preceptor or a mentor who's confident in their students' abilities and their own abilities to let somebody do something when there's a possibility that they might make a mistake, right? So you gotta let them do something, even if you don't want to. Have high expectations. Students will be pushed, and they should be pushed within limits, obviously, but they should be pushed. And if you think about what you learned the most from, you learned the most when you were challenged or made to feel a little bit uncomfortable. That's when you grow, and that's when you learn. And some of the things, too, that people don't always think that it's a high expectation, but, I mean, just the expectations of, you better be here on time. And if on time doesn't mean like 20 seconds before the shift starts, it might mean 5 minutes, before, so you're ready to go. Complete assignments when it's due. Dress appropriately. All those things are expectations that are reasonable for sure. This is the other thing that's hard for preceptors, especially for preceptors or mentors with new employees that have been there for a long time. You forget what it's like to be a student or to be a new employee. So the first thing, don't assume, because you know what happens. You see the illustration there for you. You'll make an ass of you and me, in case you didn't know that, for the 2 people in the world who didn't know that. But anyway, so don't assume things about the students, that they know something, that maybe they don't know. And they have a lot of new information, especially the real new students. They have a lot of information coming in, and you try to remember what that's like. Or if you're a new employee, you're trying to remember, the fire safety video that you just watched and all that, right? That you have lots of stuff to learn. And so, be patient a little bit. And the other thing is, if they haven't used, an IPPV machine since last year in lab, or they haven't, calculated a cardiac output since they learned that in hemodynamic monitoring class, don't expect that they will be able to do that without a little bit of review. So if it's something they haven't used very often, maybe they haven't used an oscillator very often, so you might have to go review that a little bit. So, and don't do when I was in school, back to my preceptor who could dismantle the IPPV machine. with tweezers. So also remember they don't know as much as you do, and there are preceptors, and we all know these people. You're thinking of a list of names in your head right now who gets annoyed because the student doesn't know, fill in the blank, but it's something that maybe you have to have lots of experience to know. They don't know as much as you do, right? They don't. The new hire doesn't know as much as you do. The students don't know as much as you do. They haven't had as much experience. They haven't had as many experiences. And we have all probably been berated by a preceptor who expects you as a student or a new hire to know the same thing that they picked up working in the ICU for 10 years. So be careful about that. So this is a kinder, gentler slide. Be patient, supportive, and encouraging. But you know, being patient is like, you know, let them ask questions. Make an environment where they feel free to ask a question of you, and you can, you know, encourage that. So if you encourage questions, you make sure that they get it, and you put a good clinician into the world. And I used to be, when I first started precepting and teaching too, I used to be afraid. I lived in fear that somebody would ask me something that I didn't know. And really, no one cares if you don't know. What they care about is if you find out the answer and get back to them. That's what they care about. So it's better to say, I don't know, let me talk to, you know, whoever, look this up, do whatever, and I will get back to you, you know, and set a time to do that. And people are perfectly fine with if you don't know something. And, you know, if you're not encouraging, then it's hard to be patient and supportive. So those traits fall into place naturally, I guess. But on the other hand, the preceptor who is always asking the students intimidating questions, kind of trying to make them get the wrong answer so that, you know, to break them down, that's an environment that's just, you know, not only is it detrimental to the learning process, is it, you're not helping them become a good clinician, which is what you're supposed to be doing. Oh, be enthusiastic about RT. And we all know these people. You're making another list in your head now of people who are like, oh, I can't believe you know, there's no place in this institution for growth, and the administration is horrible. And you know, kind of try to remember what you like about it, because that's disheartening for somebody who hasn't even graduated yet, and then they hear about how respiratory is a bad career choice. And you don't even have to say it. Remember, 92% of communication is nonverbal. You don't even have to say it out loud. If you have a negative attitude, people pick up on that, right? So try to kind of remember things you like about your job. It might even help you as a preceptor or a mentor to have a little bit higher job satisfaction if you try to think about, you know, what do I really like about this? Why do I like this? So if you can't say something nice about respiratory, don't say anything at all. So evaluation, let's talk about evaluating performance. Thank goodness there are checkoffs. Am I right? Because they define the criteria pretty well, and that's pretty objective. You skip this component and this component and this component, and so that's why you have to get a U. So that's, you know, checkoffs make things more objective, sorry. But you have to, you know, all those are tasks and criteria that are clearly defined. So that's, you know, kind of at the level of the checkoff, and probably the school is doing that, or if it's a new hire, your institution has done that. And when lots of preceptors are involved, because usually you don't have the student, you know, the whole time you're there, if you're going to evaluate their performance, make sure you talk to everybody that, you know, had interaction with that student, so that you can evaluate the person fairly and, you know, get a complete view of their performance. And the bit here about art and science, again, you've all had people, whether they're students or new employees, that have the technical part down pat, but they have more trouble with the communication and the social aspect of patient care. So, you know, if that's the case, it's easier to fix the other part, right? Because technical competence can be, you know, generally be fixed with practice. Social skills, again, you got to practice that. And it's not so easy to practice maybe, but still it's a, you know, something that you can't ignore, because you know, and you have students too that they're doing a ventilator rotation and they're so concerned with looking at all the knobs and or entering things and writing things down that they forget there's a person on the other end of it, of the, you know, of the tubing. So that's, Important. So evaluation and feedback. So it should be all these things, you've heard 1,000 times. And don't, somebody should never be surprised by the evaluation that they get. So if you get a summative end of quarter evaluation, that should never surprise people, right? So if there's something wrong, you need to talk to the student or the new employee as soon as possible so that they have time to improve. So, and you want to give them, specific advice on how to improve. So not only are you providing specific examples of here's how I see this behavior play out over the course of 2 weeks that you've been here or whatever. Here's some advice. Here's some ways to fix that. And you have to be, just kind of nice about it. Like, yeah, when I was a student, I used to do, and use yourself or use somebody else, so they don't feel like, yeah, I'm the only person that's screwed this up, right? And prompt, when it happens, give the feedback. Don't wait 2 weeks and then say, a couple of weeks ago when you did fill in the blank, that was not good. And I also think it's human nature not to tell people often enough when they're doing a really good job. And this is true your whole adult life. Your boss isn't like, oh, you did a great job at fill in the blank, but you sure get called on the carpet fast enough if you mess something up, right? But they don't tell you if you're doing something good. So I try to do that with students too, that if you're doing something good, tell people so that the only time they're getting feedback isn't just negative, which is kind of what we tend to do. So make an Oreo, a feedback Oreo. So you should begin with a positive, right, because that sets the tone for the session. If you begin with a negative, the student sometimes gets upset because it's a criticism and then they don't hear anything else you say. And if you're educators, if there are any educators out there, or people have ever been evaluated, that's probably all of us now, you can get 100 good comments and one bad one, and then you're like, why would they say that about me? Right? That's what you focus on, and students are no different. So begin with a positive because that kind of sets the tone, and then make sure you finish with a positive because you want them to leave on a positive note. And they may have an emotional response to it. They might cry. They might slap you. No, I'm kidding. But people get emotional if you're giving them criticism, even if it's constructive. So be calm. Stick to specific examples. Don't speak in terms like you are lazy, you are slow. Talk about the behavior, right? So make sure we do all those things. And what about attitude? Measuring attitude is not so easy. And we've all had students where you can say, and we all, like if you say somebody has a bad attitude, we kind of know what that probably means, right? But how do you quantify it? I mean, if you're going to tell, you shouldn't ever say to somebody you have a bad attitude. You have to quantify it and say specific examples. And again, you were a little abrupt this morning during Mr. Jones's treatment. And Mrs. Jones's nurse said that seemed like you were rushed when you were doing the treatment and you really didn't make eye contact, or you didn't seem like, you thought it was important to do and you left the room. Specific examples that, that you can address. So this helps to get to the reason for the behavior if you have a conversation after that. Like, okay, so I'm giving you these examples of things you did, that weren't so great. And then maybe say, you seem like upset, or you seem distracted, you seem frustrated. Is there something going on? So that might help to get to the reason for the behavior based on what they tell you. So maybe, they don't have a bad attitude about, it wasn't about the patient at all, which it never is, right? Often it's about something else that's going on that sort of bleeds over into clinical. So, and the other, thing I'll say about that is if you create that environment, just a little bit more, where I'm learning something about you as a person, and I want you to ask questions, I want you to be, when you graduate and go out into the wide world, I want you to be a good caregiver, right? If you set up that kind of environment, then they're more likely to tell you what's going on if you say what's going on. If you're the intimidating sort of person that's like, I have a student today and I hate it, then they're not going to tell you anything. You're never going to get to those types of that type of a level where they'll tell you something and you can fix it. So hopefully if you bring it to the student's attention, you can also communicate that that's something you need to be aware of so you can change, and here's the other thing, which is like a note from Captain Obvious, but it doesn't hurt to explain that, listen here, if you have a bad attitude or are rude to your coworkers, that will make your life, miserable. So there's a practical reason to be nice, especially if it's a new employee. Listen here, you're going to be working with these people for the next however many years. You might want to be, a little bit kinder, a little bit nicer. So evaluating attitude, just make sure you have specific examples and see if you can, maybe get to the heart of it. So there I've droned on for 50 minutes, and so let's take a little time in case you have questions.
Hi, Crystal. We do have questions. We have some excellent questions. Okay,
right.
So we're going to start chronologically at the very front when you were talking about students and goal settings and planning for their day and competency. So the first question is about competency. Is competency assumed for the students when they are presented to the preceptor on a planned basis from the school? So I'm the preceptor, I have a student today, should I expect competency for certain activities?
I think you probably should. I think that if they're doing, a rotation on oxygen therapy right out of the, maybe that's the first thing they do, you can assume that they have passed checkoffs on that in lab and that they have covered that information in lecture. And if, you talk to the because that's the way they set up. That's the way it's set up, right? You hear it in lecture, you do it in lab, then you do it in clinical. So I think you should be able to assume a certain level of competency. And having said that, though, I also will say that sometimes they just lose their minds and they get to clinical. And even if they've had it and done 10 checkoffs on it, when they actually have a patient, they just fall apart. So I think you should be able to assume competence, but I don't know that. I think that's not always what you get.
Thank you. And the next question we have, shouldn't the students also have goals that they can verbalize for the preceptor to help them toward their goals?
Yes. No, I won't give you yes or no. Yes, absolutely. And that's back to the self-regulatory piece of it. It's your responsibility. You have to take responsibility for your learning. And maybe, and you have goals generally because the student is coming for a rotation for a particular thing, right? Or to do a particular treatment, learn a particular skill set, be exposed to a particular environment. So the educational goals are set, by you in the program, and you have goals for them, but they absolutely, if there's, like the person I talked about who, and I'm using this as an example, but it could go the other way around. So maybe they love to be in a fast-paced environment like the ER or the ICU, and they're in rehab and they're just bored. Well, then you better find something you like in rehab and find it today because you're here for a week or however long, and that's on them to get something out of it because we all know you get out of it what you put into it. And so that's on the student. And yeah, I think if the student won't do that or can't do that, then maybe, that is a call to the program because I think that's absolutely fair to have them come up with some goals. So I hope that answered the question.
It does. And as a matter of fact, it springboards nicely into the next questions that the next question that was posted. So you mentioned at the beginning of your response about the program and the preceptor making goals for the student. I'm going to go out on a limb and say that that's not always the case because one of the participants said if the program or faculty does not involve the preceptor in goal setting, isn't that also a challenging situation?
Oh, yes, you should quit right now. No, I'm kidding. Yes, that is a challenging situation because then that means you should get paid a lot more because you're doing the job now of the educational program. So, I wish I could talk to that actual person because I have a follow-up question. So students are coming into the place without specific goals? I don't even know how you would do that because how do you know? Right? I mean, I don't even know. That I think that's not good. If they're sending out of clear or involving you in if this is your institution, you should be involved in that planning. I need students to do this many MDIs and this many, blood gases, and yes, we can do this, but we can't do this. We rarely see, non-invasive ventilation, so we can't do that. I think the preceptors, I think it's important for everybody to be at the table when that stuff's getting put together. So that is challenging. So maybe, a call to the place to say, hey, listen, could we possibly, get involved the next time you have like a clinical planning meeting or next time you have an advisory committee meeting or something, so we could put our 2 cents worth in. And again, you can kind of go off the same, menu to say, okay, well, you've diagnosed the problem, right? And then think of some kind of intervention or a way to say, can I be, because people will let you do more usually, right? If you offer to do something more, they will let you. So if you said, I'd like to be at the table when you're talking about clinical placements, or at least have some input via email or something, I would ask to be involved in that, because that is challenging for you as a preceptor if you don't know, or if you're not involved in setting goals for your own institution.
So I'm thinking back to my own experiences as a director of clinical education and a program director and a preceptor in my clinical days, and I'm getting this vision of the director of clinical education, the faculty, the program director sitting down and writing out objectives for those clinical rotations, and how much integration of the clinical site goes into making those objectives for that rotation, and how the end preceptor actually has input into those. So might a good course of action be, if you're a preceptor, if you're a frontline clinician preceptor who doesn't participate in the creation of those objectives, that you should talk with your supervisor or department educator to say, hey, such and such school is here, we were looking at these objectives, these aren't 100% appropriate for our students, here are my recommendations? Yeah,
absolutely. I think if you have that person there, then that's the chain of command. But if you don't have that person there, maybe you just, because some places do have a director of education in the department, the person that handles that. And so if you do have that, I absolutely agree with you. And if you don't, I think, then, maybe just a call, just a, conversation with the program, the educational program, I mean, to see if you could, there's some way you could remedy that.
So our last question is actually about feedback for preceptors. So if I'm not mistaken, the Commission on Accreditation for Respiratory Care has a requirement that students have the opportunity to evaluate all of their preceptors.
Yeah.
And should that information be provided back to the individual preceptors at the end of the term?
Yes. I absolutely think if somebody's going to evaluate you, you ought to see what they say, because it reinforces things you're doing well, and it might give you some tips for, how to do things better. And some of it will be baseless, and just because they don't like the, what they did that day, they will, they will write that down. So some of it you have to take with a grain of salt, but I think you should absolutely have access to see that. Because just like, here at OSU, we get evaluated by the students at the end of every semester, and they make comments and they do the numerical evaluations, and we see those. If you wouldn't see them, there's no point, because the point is to make you a better preceptor, right? So, and you have to have feedback in order for that to happen. So yes, I think you should have the results.
Well, Crystal, thank you again for joining us today. This has been a phenomenal session.
Good. Thanks for having me.
For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you are watching this program as an archive, this concludes our presentation.